dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present No Thrombosis Live Inbox, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of interventional cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected course director, Dr. M.S. Hiremat sir. Sir is director at Cath Lab Ruby Hall, Pune, President CSI 2017, Program Chair CSI Conference 2016, Convener National Interventional Council of India. Sir has proctored many interventional cardiologists and has given live courses across the globe. Sir has participated in some groundbreaking clinical trials. Due to some personal reasons, sir couldn't join today's program. He is not keeping well, but he suggested that both the moderators will take today's program ahead. But we thank Dr. Hiremat sir for his continued commitment and guidance to us for running this program regularly. His expertise and fan following has made this program a resounding success. Our distinguished moderators, Dr. Jabir Abdullah Kutti sir and Dr. Neeraj Prasad sir, are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against the global health challenge of cardiac diseases. So let me have an honor to introduce our distinguished moderators for today. Dr. Jabir Abdullah Kutti sir is Senior Consultant Cardiologist and Director of Clinical Research in Cardiology at Lisi Hospital, Cochin. Sir is Member Secretary of Institutional Review Board at Lisi Hospital, Cochin. Sir is Vice President, Kerala Medical Association in 1986 to 1987. Sir was Secretary, Cardiology Society of India, Kerala Chapter in 2008 to 2012. Sir is National Executive Committee Member of Cardiological Society of India. Sir is Honorary Secretary of Society for Heart Failure and Transplantation. Sir is Organizing Secretary of Annual Conference 2020 Society for Cardiac Imaging and Physiology. Sir is Secretary of Cardiovascular Research Society. Sir is faculty at various national and international conferences. Sir has various publications and textbook chapters to his credit. Sir is also editorial board member of Indian Heart Journal. A warm welcome to you, sir. Thank you for joining. It is an honor for me to introduce our moderator for today, Dr. Neeraj Prasad sir. Sir is Associate Director of Cardiology in Medanta, Ranchi. Sir specializes in procedures such as coronary intervention, primary PTCA, valvular heart discharge intervention procedures, congenital heart disease intervention, pacemaker implantation, ICD, CRTD. Sir is recipient of Young Cardiology ISC Award 2000. Sir is pioneer in interventional cardiology Jharkhand Award. Sir has published articles in various reputed journals. Thank you, sir, for joining today's program. A warm welcome to you. I would also like to introduce and extend a warm welcome to our esteemed speakers for today. Dr. Vaibhav Patil sir is Associate Professor in Department of Cardiology and Consultant and Interventional Cardiologist at Bharati Vidyapit Medical College and Hospital, Pune. The case which is presenting today is Stent-assisted coil embolization technique. Thank you, sir, for accepting our invitation to present the case. Let me have honor to introduce our second speaker for today, Dr. Partho Chaudhary sir. Sir is interventional cardiologist at Mediterranean Hospital, Jamshedpur. The case which is presenting today is Retrograde RCA CTO in case of ischemic DCMP with severe TVD with CKD. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the opening remarks and context setting from our respected moderator, Dr. Jabir Abdullah Kutti sir. The meeting will proceed further with the case presentation on stent-assisted coil embolization technique by Dr. Vaibhav Patil sir. Following this, we'll have a discussion on this case where all the faculty members will participate. The second case on retrograde RCA CTO in case of ischemic DCMP with severe TVD with CKD will be presented by Dr. Partho Chaudhary sir, and then it will be followed by discussion among the faculty members. Post the discussion of second case, we'll have concluding remarks by our esteemed moderator, Dr. Neeraj Prasad sir. I request audience to put their questions in the chat box so that we can take up those questions in the end. So without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of interventional cardiology. I request Dr. Jabir Abdullah Kutti sir to share his opening remarks on today's topic. Over to you, sir.
Thank you. Thank you, Dr. Rishikesh. It is indeed a pleasure to be here with Dr. Neeraj Prasad and the youngsters who are going to present their cases, and also I'm sure there are a lot of spectators across the country who are watching this program. So if you go for any interventional meeting, the largest number of audience will be in sessions where there are case presentations, because a case, a difficult case, a complex case, or a complication. So a case can speak much more than volumes of literature, and it goes straight away to the heart, and it helps at times when you are in difficulty. So when a case is presented and discussed, it helps us a lot, and we all learn a lot of things from it. So it's a combined venture of a discussion, understanding, sharing, and learning opportunity for the faculty as well as for the delegates. And first of all, let me thank the two cardiologists who are going to present these beautiful cases. I'm sure these are all exciting cases. From the caption itself, you can see very rare cases and tough cases which they are going to show, and I'm sure we are all going to learn a lot of things. So let me congratulate Emcure for this endeavor which we had. I was also part of the previous no cloud program where we had fantastic discussions once or twice a month for a long period. At that time it was COVID. Then there was a break, and now we are back into action. So I must congratulate these people for their endeavor, and I'm sure we all will benefit a lot. And I must introduce our Dr. Neeraj Prasad, who is from Ranchi. I'm sure we all will learn for an active discussion from his part. So let me invite the first presenter, Dr. Vaibhav Patil. He is from Pune itself. He's teaching faculty also in the Medical College at Pune. So please go ahead with your presentation, Dr. Vaibhav.
Hello. Thank you, sir, for introduction. I'm very happy that this is my third presentation in this forum, third case. So, this is a case. 55-year-old female, non-diabetic, had a history of chest pain and dyspnea on exertion prior to admission for 24 to 48 hours. She had minimal changes, STT changes in 2-3 AVF and T inversions in V1, V2. She has a status post PTCA to the right RCA at the mid part. Ejection fraction was preserved, and she was presented. This is an angio, what we have done. I am showing plasty with angio only. So at the mid part, she had stented 4-5 years back, and proximal part is having lesion. So the left side, she is having one aneurysmal dilatation at the LAD at the mid LAD at the diagonal level. This RC we want to do first actually. So I have taken this OCT run. Here, here I found that before the stent, her proximal part, we can see from 25 to 40, we can see there is a MLA is decreased and the fibrous lesions were present. So it was ISR of the proximal part of the previous stent. It was 5 years back angioplasty done. So I have pre-dilated the lesion with a 2.75 12 balloon and 14 atmosphere. This ostial RCA to mid RCA stent, the ISR was stented with a 3x33 stent, and the 10 atmosphere was dilated. So post stenting, the result was fine, and it was done. So the main crux of the this case was when we are done angio. That time she had this. We can see in the second film she had this aneurysmal dilatation at the mid LAD level at the diagonal, after the diagonal. So, and it was the opening of the aneurysm is such that it is not from where that aneurysm is arising. Either it is arising from the diagonal, or it is arising at the level of the bifurcation, or independently only on the LAD level. So in any view, it was not very well visualized. So I have done OCT for that, and during the OCT, I found that the mouth of the aneurysm is very large. Uh, this is the case, but during that time, proximal LAD is having tight lesion. So as soon as I have crossed the wire, OCT shoots were taken, the patient was crashing. So proximal LAD initially stented with a 3 into 15 millimeter stent. It was post dilated, and after that, when the patient settles, I have taken again the same shoots and OCT shoots. So these are the OCT shoots. Here after the we can see here in the second film, the area what it is shown as 8.65 millimeter square. Here you can see the D part whole is the aneurysmal dilatation, and the neck of the aneurysm was very wide. So what to do with these lesions? As it was previously, the patient does not have previous angio films, so this aneurysm is developed now, or it was with previously, and previous interventionist had not tackled this. So whether to do or not to do was the discussion. But with interventional radiologist, who is my friend, what I have seen from their cases, they do these kinds of stent-assisted coiling for the neuro cases, right? So after discussion with those people, I have taken this patient with uh, one coil. The stent was initially put 2.5 into 32 stent parked distal to the aneurysmal dilatation. The mid LAD aneurysm was cannulated with this microcatheter by using the synchro wire, and this aneurysmal sac was filled with this coil, 3 millimeter into 3.3 millimeter coil. Uh, During this, the with the help of the microcatheter, and the microcatheter was removed, and the LED stent was positioned as soon as the coil was inserted into the aneurysmal dilatation. So this overlapping segment at the coil with stent, it was not visualized in any angio views. Crystal clear, it was not visualized because the neck of the aneurysm was not visualized. So OCT, initially OCT run was shown. Still it was confused that it was coming from the LED itself, was diagnosed with OCT only. Then I have taken the coil and then stent. So this is the third film, which shows the coil is getting deployed in the aneurysmal sac, and the microcatheter was there, and the micro was taken out when the coil got deployed itself. So this third is initially the microcatheter till the tip of the aneurysm, and the coil was inserted. The Here, as soon as the coil got inserted, the stent I have taken back so that it should not fall into the true lumen of the LED. So it might be very dangerous, or the whole circulation gets stopped, because when I was doing the proximal dilation only, patient got hypotension and severe chest pain. So this was again one more risk at this during this case, that this coil get come into the LED circulation, and it got stuck everything. So with as soon as the coil got inside the aneurysm, I have taken the stent back, and it got overlap with the previous distal end of the previous stent. So this is the result, and we can see the diagonal mild proximal disease was there. It was initially also there, but it was not knocked down. So diagonal was also flowing distally. The aneurysmal sac got filled with the coil, and the LED having good flow. And after that post dilatation I have done, and this is the last shoot which shows. Then OCT I have taken whatever the neck of the aneurysm was there. Initially it I thought that one more coil I can use it, but with only one coil it got sealed, so I have not used the second coil. So this is the last shoot what I have seen after taking wire out. The aneurysm was sealed, and the proximal LED and mid LED was stented with the separation of the aneurysmal dilatation. And the luckily that coil not came into the systemic circulation. That one chance was there during the coil stent assisted coil embolization technique. So this thank you for patient listening.
Thank you, Vaibhav. Excellent case. Dr. Neeraj, would you like to take up the discussion?
Only one thing I wanted to stress is that if there is a artery and it has a blockage and then there is an aneurysmal growth, then what should be the approach? The approach is that what we used to do before only, and we still do, that we do the stenting with a stent which has a coated. There is a almost semi-membranous coating is there, and then you go and then inflate it there, and then it recovers very well nicely, and there is no risk of rupture of the artery or aneurysmal aneurysm. So it's better to do that. Yes. Otherwise, you covered all the things with. Okay.
Great, Vaibhav. There are two parts of your case. One is the right coronary artery, which had in which there was a peristent restenosis. I saw that angiographically. I thought it was a borderline lesion of that peristent restenosis, and your MLA was 2.8 in an OCT. In fact, we don't have a real recommendation in the OCT regarding what exactly is the cutoff for a minimal luminal area below which you should really stent. Did you do an FFR for? Did you do a FFR for that thing?
No, sir. FFR not.
It was 2.8. That is what I remember. It is 2.8.
Yes, 2.7. Yes.
The non-LM cases, the previous concept was somewhere around 1.8. If the lumen is less than 1.8, it seems to have a significant FFR correlation with the lumen area of less than 1.8. So 2.8, I'm not sure whether we should go ahead straight away with a stenting without without demonstrating ischemia in that particular area. But the stent result was so good. You didn't show us after post-stent OCT. Did you take a post-stent OCT?
For RCA, not. RCA, I have not taken, sir.
It was an overlapping stent. What was the size of the RCA stent, initial stent? It was well endothelialized, and the restenosis, it was basically a fibrotic lesion, and in one part it was a layered lesion. It was layered lesion, so it was not a mostly it was a homogeneous thing. At some part it was heterogeneous or a layered lesion. We could not see any macrophages or cholesterol crystals there, and no what do you call the neo revascular what do you call the these what you call is what you see in the neoatherosclerosis. It's when you use microchannels, no microchannels. So it's mostly a neointimal proliferation. So in a neointimal proliferation, would you like to do a cutting, use a cutting balloon so that you can prepare the lesion very well and then go ahead with the stenting, which can give the best luminal area. So everything depends upon the minimal stent area. So you can have a expansion, a good stent area. If you cut the fibrotic lesion, sometimes though the fibrotic lesion looks like very soft thing, it may it may recoil like anything. You will not be able to open it up well, but your stent could open it up very well. So when there is a fibrotic lesion of ISR, one thing many people would prefer to prepare the bed very well, cut the fibrotic lesions with a cutting balloon or a scoring balloon, then go ahead with the stent of the distal vessel size. So was it a 3 millimeter stent or a 2.75 millimeter stent?
3, sir, 3 millimeter.
It was a 3 millimeter. And did you post dilate it with a 3.5?
3.5.
It's a post.
I have post dilate.
Excellent result.
Yes, sir.
And then the aneurysm is always a complex thing. And previously, we were afraid of even stenting the area where there was an aneurysm, because we were all afraid if you dilate the lesion, even with a balloon, the aneurysm may rupture. If you dilate with a stent, the aneurysm can rupture. But later on, we all gained some experience as well as courage. Many a times, if it's not a very huge aneurysm, we'll just put a stent across, and mostly the aneurysm will develop a thrombus and it closes off. Another option is, as you rightly pointed out, it is a covered stent, but the prohibitive risk of restenosis. And the third and the most effective method is what you have done, and you did it very correctly. The only problem is we should be very meticulous in planning the size of the coil to be put, because it's not a very huge aneurysm. It's a moderate sized aneurysm, or else it can come back into the main vessel of LAD. So you could put in the microcatheter, put the coil inside, then pull back. The microcatheter was taken out of the aneurysm and pulled the stent back across the aneurysm and stented it without any issues. Did you post dilate that stent?
Yes, sir. Yes, sir. Mid LAD stent. Post dilated. Yeah.
And always. It's always a frightening thing to do the dilatation in an area where there is aneurysm. There is always risk of rupture, but you could do it well with your technique and without any complications. Congrats.
Yes, sir. Yes.
Dr. Parthav, would you like to comment on this case?
No, sir. Already, it was discussed very well. I don't have any.
Okay. Dr. Neeraj, shall we go ahead with the second case then?
Okay, go ahead. Let's go.
Parthav.
Thank you very much. Thank you.
Yes, sir. Thank you. Thank you very much.
Thank you. So please share my slides.
Jayani, can share this?
Next slide, please.
Make it full screen, please.
So this is a case of a 70-year male with old MI. He admitted to us with recurrent episodes of heart failure. Echo was showing global hypokinesia. LAD territory was more hypokinetic with EF of about 30 to 35%. Serum creatinine was raised. He was on maximal medical therapy, including ARNIs, diuretics, antiplatelets. After we did angio, which was showing severe TVD. He was refused for CABG because of diffusely diseased distal vessel, as well as high surgical risk and a suspected viability of LAD territory. Next slide, please. Now, this is the left circulation angiogram. Please play the second one. So we can see that LAD, LCX, both are having like a 90 to 95% lesion, which we can easily we can do PTCA. Next slide, please. Now this is important. This is the dual injection of RCA. Please play second slide. So here RCA is like, next slide, please. Now you can see here clearly, if you'll assess this angiogram, RCA, we have a blunt stump. There is a mid-long segment CTO. Then we have distal vessel that is diffusely diseased. So usually in such cases with IGCT score 3 or 4, since it is an sort of ambiguous stump, like a blunt stump, we directly approach retrogradely because of two reasons. First is we didn't have a clear-cut stump, and secondly, since the creatinine is raised, so retrograde approach requires less dye. So we primary approach was to do a retrograde one. Next slide. These are the second thing. We have multiple collaterals, and we have selected the second one since you can see both proximally and distally. It is like there is an obtuse angle. There is an obtuse angle with obtuse angle with the minimum branches. And this first one, it is opening more distally. So that is why we choose this number one collateral. Next slide, please. So this is what I have discussed. Like angiogram, RCA proximal cap is blunt with a side branch. It is a long CTO, discalcified. A distal vessel is poor quality, diffusely diseased. We have very good quality multiple septal collaterals. And there were septal collaterals, Warner CCA1. Most of them are non-tortuous. We are having good entry and exit point. And our choice was collateral number 1. Next slide, please. When we all know, we first of all we took a workhorse wire and we took our fine cross catheter to the collateral, and then we took an injection. So that please play the slides and play the first one. Please play the slides. So we put a small amount of dye so that we can clearly visualize the connection of the collaterals, and then we changed to cyan black for surfing. Next slide, please play the slide. Next slide, please. Next slide, please. So while doing the CTO, the third step is always once we cross the collaterals, third step is we have to confirm the guide wire is in true lumen position or not. Please play the second slide. So here we can clearly see that our retrograde wire is in the true lumen position. Next slide. Now, please play. Now, next step is we took our fine cross and we crossed the collaterals to the almost proximal end. Next slide. No, sir. Then we exchange. Please play the slide. Then what we did, we exchanged the retrograde wire from Fielder FC to we took a penetrating wire, Conquest Pro, so that we can penetrate the distal cap. Next slide, please. Next step is obviously wire externalization, which we did with the help of RG3 wire. And then what we did, we dilated the proximal CTO segment with 1.5 into 15 mm balloon. Next, just see the slides that we can like. First slide, wire externalization. This is the important step, wire externalization. Next slide. Then what we did, we took a 3.548 long stent, dilated it well, and the target, that is ischemic free flow, is achieved. Please play the slides. So here we have like a good flow. Distal vessel is diffusely diseased, so like we didn't did anything there, but hopefully like it will slowly harvest. Next slide, please. Then next step is that externalized wire. Externalized wire is removed with the help of microcatheter. And next is this is the final angiogram where we see that the RCA is very well opened with a T-free flow. Next slide. Lastly, conclusion, that is, we see a lot of cases of ischemic cardiomyopathy with TVD with CTO, refuse for cabbage with a viable myocardium. These are the patients who get maximum benefit from CTO PCI. And when we are approaching for CTO PCI, we should have a detailed analysis of angiogram. Then what is important while do CTO is a meticulous algorithmic stepwise approach. That is very important. This is this approach which leads to a higher chance of success with minimal complications. Thank you very much.
For the great case, first of all, I think the most important thing, your approach, because you approach the CTO because it was easy to put a stent into the circumflex and the LAD and feel that the collaterals will take care of the RCA. That's the simplest approach people may take up. But in ischemic cardiomyopathy, you have to complete the revasc. You have to do a revascularization which is as complete as possible. Even then, we are not sure because with the latest data in the BCIS trial, where they could not find much benefit with percutaneous coronary intervention in patients with ischemic cardiomyopathy or LV systolic dysfunction. So if the patient has angina, of course, our intervention is, there is a what called justice in our intervention. If we can do a complete revascularization and aiming for recovery of the cardiac function, especially I think the RCA territory was, did you do a viability test? It
was done. Yes, sir, it was done, but LAD territory was partially viable. And she was refused for cabbage because of like poor target vessels.
And actually the LAD and circumflex, I'm sure you have, you could get an excellent result with the intervention. RCA was the toughest one.
Yeah, LAD L6 were very simple. The thing was about RCA.
Right. And though it was, even if it is only a mixed viability in the LAD territory, I think it is worth revascularizing that territory. If it is only a 10% improvement, that can contribute significantly to the improvement in the LV ejection fraction. And you did fantastically well. And I think your approach was right because you wanted to give the the smallest possible amount of the contrast for a tough intervention where the creatinine is borderline, it was 1.7 and a tough intervention. So you selected the retrograde approach first and you could get an excellent result in the RCA, which was supplying a large amount of the viable area. What is the follow-up of this patient? Did his LV ejection fraction?
Follow from last 1.5 years. He never again admitted with heart failure.
Right, absolutely. Good, great case. And I think the learning point is go for a complete revascularization in ischemic cardiomyopathy if we are intervening. And you have to take the best approach, which can use only the smallest amount of contrast. You can even think of using an IVUS guided intervention using the least possible amount of contrast in such type of patients. Dr. Neeraj, what is your approach? Dr. Neeraj, you are muted. You are muted. We can't hear you. Dr. Neeraj, you are muted. We are not able to hear you. Right.
Okay. So, very nicely presented by both, and you also commented very nicely, and it was well covered. So, once we have a LV dysfunction with ischemic episode, we have to be extra careful to manage it. First of all, that we have to, I always keep it on inotropic support like dobutamine or dopamine, unless the BP is more than 110 or the ejection fraction is at least 26%, more than 30%. Then only it will maintain. Otherwise, it becomes less than 30%, and then it becomes very much difficult. So it's very important to maintain the blood pressure so that there is no problem. Second thing is that we can go ahead and open the arteries one by one, and it will be very, and always take the artery which is very much diseased and very much severely affected. I take it that first, and then make it sure that it's all doing very well, and then other two arteries also I have taken. This has been done by me today only. I have done it, and all are fine. So other things you have covered very well, and the presenter also had covered very well. So it's good, very good.
Thank you.
So let me check if there are any questions in the chat box.
Okay, and Dr. Vaibhav, would you like to make any comments? Where is Dr. Vaibhav? I'm not able to see him. I think he came from the cath lab and presented. Dr. Partha, what is your usual approach to a CTO? Is it antegrade first, then if it fails, go for retrograde, or which are the situations where you will go for a upfront retrograde approach?
Sir, as per guidelines, there are usually 3 or 4 criteria where you can go directly to retrograde. First is when you have an ambiguous blunt proximal cap. Second is if you have a long CTO. Third is when your that CTO segment is very tortuous and calcified, where there is a high chance of perforation. Then also you can go to a direct retrograde approach. These are some of the cases where you can
here it was a blunt stump was blunt, and it's a long segment CTO which justifies your approach, and good collaterals.
Yes, sir. But third most important point is good collaterals.
Good collaterals and a reasonably healthy donor vessel.
Yes, sir. That is the most important point. That is the
no calcium, nothing. The donor vessel very healthy.
Yes, sir. They're very easy to cross retrograde.
Yeah.
And you use the Sion black to cross with
yes, sir. Yes, sir. Usually our choice is either Fielder XTR or you can choose a Sion black. But I usually select Sion black. Or if I have epicardial vessels, then my choice is like directly going into the RG3. Because we require soft wire. So if we have epicardial collateral vessels, then directly we go to RG3 wires. Otherwise, Sion black is the first choice.
In that case, always you go for straight away to the RG3.
Yes, sir. Because epicardial collaterals, there is a very high chance of perforation. I have only approached once or twice in epicardial, but both of the time I took RG3 wire because. Epicardial collaterals, it is most riskiest because there is a high chance of perforation, tamponade. Usually it is associated with cabbage. So like it is the most riskiest if you are approaching.
And many people may avoid a retrograde approach if there are only epicardial collaterals.
Many people, but the thing is, sir, retrograde collaterals are more easy to cross. But you have to careful that there is a two phase, systole and diastole. In systole, that collateral get closed, so you have to be careful. In diastole, you should push the wire. You should push the wire in diastole, but it is not very difficult. You can cross it easily, but you should be careful.
Especially these type of patients where they have ischemic cardiomyopathy, LAD territory is only partially viable, LV dysfunction, and a borderline creatinine, renal dysfunction. So a bleeding will tilt everything.
Yes, sir. But the thing is, you have to measure risk-benefit ratio. This patient get maximum benefit. After that, he didn't admit it.
I fully agree. It was a good RCA. It was a significant. Though because of the underfilled RCA, we thought that it's a small PDA or PLV before completing the intervention. Once you open up the vessel, it became a huge vessel.
Yes, sir.
And it was supplying a large area of the vital myocardium. Vaibhav, you want to make any comment?
Yes, sir. Very well executed case. So actually, in retro, we should everybody should have a very good knowledge of hardware actually. And then the case planning is important in that case. The imaging is one, and MPI means only echo is one thing, and then the thickness of the LV on echo. then we should go for the imaging, right? So the viability scanning is important in these kinds of patients. So I lost connection in between. Viability was discussed or not, I'm not sure. So if it is,
it was discussed, the LED territory was partially viable myocardium. It was partially viable myocardium in the LED territory. The rest of the territories, it was viable myocardium. So that's why Dr. Partho thought of revascularizing the RCA territory first, and if successful, go ahead with the LED and circumflex revascularization, which was pretty simple when compared to the retrograde opening up of the RCA CTO.
yes, sir. Yes, sir. Very good, very good case, sir. A good result. Yes.
Dr. Neeraj, it's your concluding remarks, and then I think we can hand it over to Dr. Rishi. We are on time.
Yes.
Are there any questions in the chat box?
No, sir. I have checked. There are no questions in the chat box.
Questions. Okay. Okay. So very well presented, and Dr. Partho.
Thank you.
It's always very important to assess the pathology, and it is different from person to person. What I have seen, the people coming from Punjab and coming to me, and then the difference, and people from Kerala and people from Tamil Nadu, they had different anatomy structures, and the process we have to adopt differently in all these cases. And that you have covered very well, and I'm happy with that. And you, the other person who is my Dr. Javed, who is very close to me also, and and Dr. Vaibhav Patil, all of you are there, and all of you know very well. And I'm very much satisfied to see that my state people, initially when I was here, they were very much lack of awareness. But now this awareness is there prevalent in all of them. So that's, I feel very happy.
And it's a pleasure to see the youngsters doing complex intervention and getting excellent results without any issues. They are, I think they are pretty confident and they know what they are doing. That's the most important thing.
And not only TVD, not only CTO, not only left main, whatever it is, we can do it easily.
The future of intervention is quite safe in the hands of these people.
Absolutely. Absolutely.
Yeah. So we are nearly at the finish line. But before we conclude, let's express our gratitude to all those who made this scientific program possible. I would like to express my sincere gratitude to our distinguished moderators, Dr. Jabir Abdullah Katti sir and Dr. Neeraj Prasad sir, for sharing their knowledge and expertise with us today. I would also like to thank Dr. Vaibhav Patil sir and Dr. Partho Chaudhary sir for their insightful case presentations. Your contribution has undoubtedly expanded our understanding pertaining to the cases discussed today. I would also like to thank our esteemed audience for their time, continued love and support for this no thrombosis program. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing and medical team at Emcure who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thank you. Good night. And we thank both the presenters who did a wonderful job.
And keep on doing all this process, because this will save more and more life and it will grow awareness everywhere. Okay.
Yes. Thank you, sir. Thank you all.